Welcome everyone to our lecture on cath lab imaging, where we look at cardiac angulations. We continue our study of the cath lab gantry system by looking at the operation of the C-arm and see the standard viewing angles for ventriculograms and aortograms. We mentioned the contrast injector, and we'll have a closer look at the orientations for viewing left and right coronary arteries. My name is John Boland. Here we have a few pictures of the gantry in our three standard positions. The middle one is straight AP, where the X-rays go straight from below the patient to the detector on top. One on the right is the LAO, where the detector is on the patient's left, over the patient's left shoulder, and the RAO, where the detector is in the patient's right shoulder. On the bottom, we have the RAO view showing the standard view for a ventriculogram. The scenario 50 can be anywhere between 30 and 50 to give you a ventriculogram. That's the heart in profile view I've been mentioning, and the dye being cleared straight up the aorta. The aortogram, however, we get a clearer view of the aorta and its structures and the valve movement, which we can barely see, but we can identify it in this longitudinal aspect, from looking at the heart from above. And this is an LAO. So the standard difference, or the main difference between the RAO and the LAO, is the RAO looks at the heart in profile and the LAO looks at the heart from above along its longitudinal axis at a bit of an angle. A bit of nomenclature here. The same images on the left-hand side of the screen show that aortogram and the ventriculogram, again in the LAO and the RAO. Remember now, aortogram is in the LAO, ventriculogram is the RAO in profile. The regions of the heart have names. The base of the heart, paradoxically, covers this segment, the superior portion of the heart, and the apex is the tip of the heart. That's labeled 1 and 3. And you can see that 2 is the lateral and 4 is the septal view. Now this is in that LAO view, but in the RAO, that is now the basal, that is the lateral, that is the apex, and now we have the inferior view and the inferior basal. When cardiologists report any abnormalities in the heart, they refer to these regions, so that, for example, if you have an apical infarct, we know what part of the heart's been affected and what vessel has been occluded. The contrast injector. I've mentioned this one before. This is what we use to get our aortograms and our ventriculograms. We load this barrel with radio-opaque contrast medium on iodine-based that shows up under X-rays, and we hook up a long, pliable plastic line to the transducer system here, and from there the cardiologist sets the taps to allow that injector. It's quite forceful, 1000 psi, to inject a large volume of dye, say 30 mils, in 1.5 seconds. That's impossible to do that by hand. Some units prefer to do their coronary artery injections using the injector here. They just set the volume to, say, 10 mils. In my lab, we have always used the injector for large volumes and hand injections for the coronary arteries. So we've talked about coronary arteries. This is just a quick peek at what our angiograms of coronary arteries look like. This is the left coronary artery. You can see this is a caudal view. We tend to ignore these slight angulations. They don't always insist on getting that to 0 to get a true caudal or whatever. And same here. That's a caudal 3, but we'll refer to it as an LAO view. What I'm showing here is the curve of the aorta. The catheter goes in from the femoral artery up the descending aorta, across the aortic arch, and here the catheter is engaging the right coronary artery on the right side of the patient, which is our left, whereas here the catheter is engaging the left coronary artery on the left side of the patient, which is our right. That'll do for this one. Notice the patient is in sinus rhythm, And what we look for is irregularities in the flow. With age, your arteries atherosclerose, and you can have occlusions or narrowings, and that's what can lead to a heart attack. So moving on to our angulations. Let's have a look at our angulations to take pictures of the left coronary artery. Now, in the middle, we have the straight AP. That's our little heart right here. What we do with the left coronary artery, we normally start with an elaeocranial view. Then we go down to the elaeocaudal. Now, this elaeocaudal is, you're down near the patient's feet from above, and you're in the patient's left side, so it's elaeocaudal. This is called the spider view because if you use your imagination, the images look like the legs of a spider. So this is one you should memorize and remember always, elaeocaudal. You can remember this along with your right ventriculogram being in the RAO, showing the heart in profile. The U-arm moves in this direction clockwise, and they take a straight caudal view. You can see how the gantry has moved from the left to the middle of the patient, and now it's moving to the right. That's the RAO caudal view, and then it rotates up to the RAO cranial view. And that is a straight cranial view. They won't necessarily take all of these pictures for every artery. This is 3, 5, 7. They may take only 4 or 5, depending on what they see. Although if they're looking for pathology, they might take more. We'll move on. Don't dwell on this too much for the moment. It's just to illustrate the movement of the U-arm around the patient. And you don't need to memorize it yet because you can follow the pattern. Elaeocranial, elaeocaudal, spider. Straight caudal, RAO-caudal, RAO-cranial, straight cranial, and of course your straight AP. The straight AP is used mainly at the beginning of a case to insert catheters, so you can have a nice anterior-posterior view as the catheter goes up the aorta. Your standard coronary angulations, and these are only approximate, they will certainly not insist on having an eleo 40 or a cranial 30 as you've just seen, but there are 6 standard angulations. Eleo 40 and cranial 30, that's the spider view. Don't worry too much about these numbers just yet, they'll come to you, but you'll notice they all lie between 30 and 40, so they're not that difficult to remember or memorize. Spider view is one you should remember, memorize. Elaeocranial, spider, and that's used to view the left main, the proximal LED, and the circumflex. Again, I'm just mentioning all this for completeness. You will pick it up as you go. In some ways, it's a little unfair to lump all this on you without participating in a cath lab session, but you've got to learn it at some stage, and having it now will put you in a good position for your cath lab placement. The straight caudal 30 for the left main, proximal and mid circ. RAO caudal, mid and distal circ and OM. RAO cranial, LED and diagonals. Straight cranial, another view of the LED and diagonals. LEO cranial, the ostial left main, the LED, and the circumflex when the circumflex is dominant. I'm mentioning all this for completeness so you're aware that there is a pattern to what they do. And the important thing is to recognize the vessel. And the angulation can be difficult to pick up. You won't get it exactly, but if you know whether it's the LAO or the RAO, and whether it's caudal or cranial, that will be enough for the moment. So this puts it all in perspective. There's a little man on the table. The bottom square represents the generator, and the top square represents the detector. And you can see how the detector moves around the patient in an arc along these positions, and correspondingly, the generator moves in opposite directions. Let's put all that together in this picture. The straight AP, used mainly for access. The straight cranial, the LAO cranial, AO caudal, the spider view, straight caudal, RAO caudal, RAO cranial. Now here I've indicated what was in the writing on the previous slide, and I think this is a better way to remember it. Straight cranial 35, LED and diagonals. LAO cranial, left main LED and circ. Spider view, left main proximal LED and circ. Straight caudal, left main proximal and mid circ. ariocaudal, mid-to-distal circ, and OM. And finally, ariocranial, LED, and diagonals. This may sound like a lot and it can be confusing, but don't worry too much. We'll come to it all. This shows you what the coronary arteries look like when we inject them at those different angles. And I hope, as with the heart, when we saw the RAO and the LAO, and you could see how the orientation of the heart changed, like a football, the coronary arteries also change in a similar pattern. I like to think of the heart as a football shape, and the LAD runs along the seam of the football. So that here, you could almost be holding that football in your hands out of the screen. That's the longitudinal aspect of the football, and that's the lateral aspect. And as the camera or the detector moves around the patient, that will rotate. So that as you hear in the ariocranial, when you go to the straight cranial, that LAD develops a little bit of a different curve, although at this stage you may not appreciate it, but it sort of flattens out that part of the LAD. Not a very good example of this here. I could forgive you for thinking that these are identical, and I won't try to convince you otherwise, but if you see this compared to this, this is a little bit foreshortened compared to that one. Cranial and ariocranial. The LAO cranial. This shows the LAD coming down here, so the football has swung around so that the LAD is here, it swung further in, and now swung in the opposite direction. And here, you're in the LAO, so you're looking at the heart from end on, almost, as you were with the ventriculogram. We'll follow through with the rest, whether it's clear or not. It'll come to you. The ariocaudal, remember where he is from a previous drawing. RAO, so it's the heart in profile. The straight caudal, can't really compare it too much, but you're looking at the heart from below. When you go caudocranial angulations, you're really changing your perspective of your view of the heart from above to below. If you get a little model, you will be able to appreciate this. You turn the heart upside down, you'll appreciate how the coronary arteries look from below. And finally, the good old spider view, where that's the LAD there, and that's the circumflex. Let's get a general overview. This is a straight cranial, that's also a cranial, and that's also a cranial. Now see how the cranials and the LAOs, you're looking at the heart top to bottom. Whereas in the RAOs, not so much this one, the caudal, you're looking at the heart in profile. And this is the LAO caudal, so you LAO, top to bottom again, but caudal, so you're looking at the heart along its longitudinal aspect. We'll move on. That was for the left coronary artery. Let's have a look at the right coronary. This will be a little easier because we only take 3 images of the right coronary, and the right coronary is anatomically much simpler. It doesn't branch into LADs and diagonals and marginals and so on. It simply has the main trunk, and it branches into 2 distal vessels, the posterior descending artery and the posterior lateral, PTL-PDA bifurcation. Remember this LAO30. LAO is the standard right coronary artery profile that gives you a C shape. You'll see that again. The LAO cranial shows you the bifurcation. This is one of those LAO where you're looking at the heart almost from below. The heart is tilted. And the straight RAO, mid-right coronary PDA. So the straight RAO, again, is that sideways, that profile of the heart. Here are the right coronary angulations. The image here shows you the angulations in the RAO, that shows you in the LAO, and that shows you the cranial 30. These are the 3 angulations we take of the coronary artery, and this shows you what they look like. The straight LAO is probably the easier one to start with. in that it gives you what they call a C shape. I'm not entirely convinced. They all look like C shapes to me, but if you believe what they tell you, this is more of a C than the others. But remember, this is the heart in profile. That's a straight LAO, and that gives you that. The distal vessels are overlapping in that plane, coming out of the screen at that level. Because when you separate them with the LAO cranial, this is where you look at the heart upside down, you can see the bifurcation of the PTL and the PDA. The PDA always goes down, the PTL goes into the screen. This doesn't have very prominent bifurcations, but usually you will see them in a patient. It's a small non-dominant system. You can see that the artery doesn't extend very far beyond that level of the heart or that region of the heart. So this patient is likely to have a dominant circumflex, where the circumflex perfuses the region of the heart that a bigger right coronary would perfuse. Some more right coronary angulations. Have a look at the LAO-cranial and the straight LAO. I like to start with the straight LAO, the profile, and you can see that's a C shape. This is still a C shape, but you can see how the bifurcation of the PTL and the PDA are separated, whereas here they're more overlying. And this is your RAO, straight profile of the heart, so you'd expect the right coronary artery to form that outline following the inferior wall of the heart. You will not always see perfect images, but you may as well get used to seeing the whole variety of coronaries that are out there. Here I've just taken 3 different patients showing you the different angulations. Starting with the C shape in the LAO, you can see how the anatomy looks vaguely similar, but every patient has a slightly different configuration of their coronary vasculature. But you can believe, I think, these are all in the same angle, even though there might be a few degrees out on either direction. This is that cranial, LAO cranial view that separates the bifurcation. So this shouldn't be difficult to remember. That's the LAO. That is the bifurcation with the LAO cranial. And your standard C shape, your RAO, where you're looking at the heart in profile. And this shows it better. But if you look at the bottom patient, his anatomy is totally different from the others. His right coronary artery curves and sends out branches horizontally along that way. And when you look at it from a different view, see how that curve changes shape as you view it from a different angle. And that is the hardest thing to get used to when you're looking at these, trying to realize how the angles change and what effect they have on your view of the coronaries. Hopefully, by the time you do your cath lab placement, you will have an opportunity to view many of these and come back the wiser for it. Have a look at this coronary artery. Let's have a look at a moving image. I hope you can see that it's an RAO view. That's the left coronary artery. A short stump called the left main branches into the circumflex. That's a pretty big circumflex. And the LAD and diagonals coming over this way. The branches that come off the circumflex are called marginals. The branches that come off the LAD are called diagonals. The branches that come off at right angles from the LAD and even the diagonals are the septal perforators. And you will see them to different degrees in different patients. So for the left coronary, left main, left circumflex, LAD, left circumflex and its marginals, and the LAD with the septals and the diagonals. Remember, septals to the left, diagonals to the right. We'll look at the next slide. And this is a totally opposite view from an LAO with some cranial angulation. It is showing a lesion right here. You can see how that LAD that was on the right side before, or the patient's left, is now on our left, which is the patient's right. And that's because the X-ray source has swung in the opposite direction, right across from the RAO to the LAO. And this is that view where you're looking at the heart more along its longish axis. But this is what coronary arteries look like with coronary angiograms in the cath lab. And this is our bread and butter, fixing stenosed coronary arteries, stopping people from suffering a heart attack. I think we'll leave this one. It's a repeat of the previous slide, which I neglected to delete. I had it earlier. My apologies. Now, let's move on to understanding the viewing planes. The same way that you held a light in front of one finger, do it now with two fingers. Let me explain. Here's your generator, straight AP, but instead of looking at just one object lying here, have a look at two overlying objects, labeled X and Y. X and Y will be overlapping on the detector. So if you have two coronary arteries that are lying in the same plane, they will overlap and you won't have a clear view. Now have a look at this. If you rotate your detector to the RAO or to the LAO, the objects separate. You can see how, with angulation, overlying objects separate and move laterally, left or right. The object closer to the source, X, moves farther away than the more distant object. You can do this with two fingers. Hold one finger in front of the other, grab a flashlight with your phone, shine a light on it, and move the phone sideways, left and right. And you will see, if your index finger is closer to you, that index finger, the shadow, will move much further laterally than your second finger behind it. That's an easy way to remember how shadows move, X-ray shadows, with changes in angulation. So the closer artery moves away more laterally, and you can try this using two fingers and a flashlight. This slide shows three angulations for a left coronary artery, AP, cranial, and RAO. Don't worry about the slight difference in angles, they're relatively immaterial. This is the LED, here, here, and here. What I want you to appreciate is how the perspective of the LED changes from looking at the heart straight on to cranial. Cranial angulation tilts the heart forward so that you have a clearer view of the proximal end. Compared to this cranial view, that AP is foreshortened around this region. That is the benefit of cranial and caudal angulations. You can eliminate foreshortening and stretch out a vessel so you can see it more clearly. Similarly with the RAO, that's your LED in that football shape, the profile, LED here, septal perforators you can see more clearly, the circumflex, and the diagonals are moving across in an arc. Just appreciate that rotation from AP to the RAO. You can see how the LED has rotated to the right, AP to RAO, and how the cranial view, the heart has tilted forwards. You can practice that looking at your own heart. These are the same images but with different angles. Straight AP again, this time RAO and RAO caudal. LED, LED as before, and the RAO caudal view. Now, the straight AP as before shows the LED here, and the RAO as before shows the heart in profile. These two are RAO views, so you can see the heart in profile. And even the straight AP shows you that heart with the seam of the football running here. If you think of the LED as a seam of the football, you'll have a better understanding of the rotation process. We won't labour the point, we'll go through these quickly. Your spider view, LED up here, and the branches coming off, that's the circumflex, look like a spider. Eleocranial. It's worthwhile remembering this view. Eleocranial, this view, the LED, but the heart has rotated to a more vertical position than that round spider view. RAO views, RAO views, RAO views. You can appreciate that lateral, that profile of the heart in all your RAO views. Whereas in your LAOs, you're looking at the heart more from top to bottom. So that is your take-home message. LAO, you're looking at top to bottom. RAO, you're looking at the heart in profile. You'll learn the different vessels as we go. We'll leave it at that, so I'll close the lecture.